Hi, I'm Dr. Sam Mann, and this is my podcast, Beyond Conventional Medical Thinking. So, who am I and what is this podcast about? I'm a physician. I spent the past 40 years at New York Presbyterian Hospital, Weill Cornell Medical College, and I specialized in hypertension and internal medicine. I combined practice and research. I published 65 papers, a dozen book chapters, and 3 books, most recently, Hidden Within Us, A Radical New Understanding of the Mind-Body Connection. And this is my podcast. Physicians acquire knowledge from 2 sources. One source is the medical literature, the medical textbooks and medical journals, which have scientific articles and convey a lot of important information. But there's another source for what we learn, and that's from our clinical experience. And over decades of clinical practice and seeing thousands of patients, one has to learn something. And we do. And we learn some things that are not in the books and that most patients and physicians are not aware of. We learn important things from our experience, observations that lead to different ways of treating things that are not mentioned in the textbooks, and yet they make sense, and they do not disagree with what we know of pharmacology and physiology. They're right in sync with that, and they make sense. And importantly, it's relevant to many medical conditions: hypertension, chronic fatigue syndrome, inflammatory bowel disease, migraine, ADHD, and others. So this is very relevant stuff. And a key factor here is the issue of individualization of treatment. And guidelines tell you what you should give to everybody, but in fact, different patients are different from each other, and what's right for one patient is not the best for another. And that's where clinical judgment and clinical experience come in to offer different approaches to get better results. And what I'm saying is not just theoretical, because they lead to different treatment. And the important thing is the treatment that it leads to is both safe, simple, inexpensive, and usually quickly evident in terms of whether it's going to work or not. So this is not just hypothetical stuff. This is very practical in terms of treating patients. And again, I want to emphasize individualization. Every patient is not the same. Patients differ from one each other. We do best when we figure out the alternative that fits best for that patient. So how did I become aware of these treatment options? Obviously, from clinical experience, you see thousands of patients, and here and there you notice something and raise an eyebrow, and then you notice it again in another patient. And after a while, you realize that, and it may be a small percentage of patients or more, that there's something different here than what the books tell us. And again, consistent with what we know about the physiology and pharmacology of the condition we're looking at. Sometimes it's a patient who tells me. I give them medication for condition A, and then they come back in and condition A is doing well. He says, oh, by the way, I have condition B, and that also got better. And it's interesting. You make a mental note, and then you notice it again, and it may be months and months later or a couple of years, and you notice in other patients that same thing. Well, this wasn't intended for that, but clearly it helps that. And when you look at mechanisms, it makes sense. The other source is what we call the N of 1 experiment. And that sounds dirty. You are doing an experiment with the patient in our room. But for example, when you have a patient who's on the recommended regimen and they're okay, but they're not doing as well as they could, well, do we settle for that? Or, well, let's try this and see if it helps. If it doesn't help or if it bothers you, we can stop it. If it does help, maybe we can stop something else that wasn't working. Finally, Why are there no published studies on this? Well, that's the nature of clinical practice. A physician sees thousands of patients. He doesn't have time to go through everything you need to go through to do a formal experiment and publish it. We don't have time to seek to apply for grants. We don't have time to apply for approval from the Institutional Review Board, efforts to get funding, staff, doing a randomized large placebo-controlled trial, statisticians to analyze the results and report a paper. It's just not possible when you have a mostly full-time practice. So that's why, for most physicians, these observations will die with the physician. They don't get translated into formal studies. Also, most of the studies are dominated by newer drugs and procedures that can generate a lot of income for the manufacturer, and they have the money to invest to prove that that procedure is helpful, that medication is helpful. When it comes to older drugs that are off patent and not expensive, nobody's going to fund research for that. It just doesn't happen. And observations we make with older drugs, they just don't end up in the literature. Well, researchers, on the other hand, are doing less of clinical practice, so they're not aware of what you learned from the experience of treating thousands of patients. They're less likely to be aware of that. So they're doing where the research is pointed at from theoretical and chemical, biochemical, and pharmacologic and procedures. They're not initiating the research from clinical experience. So here's a sample of upcoming podcasts. This is a list of some of the podcasts. It'll give you a sampling of what it's like. One, there's a commonly prescribed bestseller medication for high blood pressure and for certain coronary heart conditions. And it can cause mental dullness, mental fog. I've noticed this in patients. It's in a minority of patients, not in most patients. But in the cases where I've seen it, patients and the physicians had no idea that this drug was causing it. And these patients remain on those drugs indefinitely and suffer from the mental dullness. I'm going to be describing the medication and the simple option that can resolve that. Hypertension. It's very common, 100 million or more, but it's overdiagnosed and overtreated, often because of the way blood pressure is measured. And we'll talk about that. Another podcast, the mind-body connection. There have been decades of research. Hypertension was considered the classic mind-body disorder. Decades of research, anger, anxiety, measuring them, relaxation techniques. But after decades of that research, it led nowhere. Yes, you get angry, anxious, your pressure goes up in the moment in anybody. That's not hypertension. That's normal physiology. They could not prove that those emotions cause hypertension or that relaxation techniques help it. I'm going to introduce a new and very different mind-body connection, new and different understanding of it that's relevant not just to hypertension, but to many other common conditions that we really don't have a good handle on yet. And that includes, for example, chronic fatigue syndrome, inflammatory bowel disease, migraine, and others. And it offers a new understanding and new treatment avenues. And we'll be talking about that. One of the topics of the podcast will be chronic fatigue syndrome. We really don't know well how to the cause of it or how to treat it. This offers a new understanding that I think opens doors. The FDA approval process, it's important to have that to prove that a drug is effective and safe. But there are shortcomings in the process that greatly affect how we practice medicine. Another podcast, Often people are under the impression they should drink 8 glasses of water a day at least. For some patients, that's true. For others, it's not necessary. And for others, it can be harmful. And we'll talk about where it's necessary and where it's harmful. Another topic is the diuretics, given for high blood pressure, given for heart failure. And there are better ways to prescribe them to get the better result and fewer side effects. And this comes from learning from clinical experience, and we'll be talking about that. Finally, ADHD, attention deficit hyperactivity disorder. Stimulants are the usual treatment. They're not that great. There's another treatment that can be very helpful that does not exist in the literature, does not exist, has not been studied, and yet is helping a lot of patients. And no physicians or patients are aware of it. Psychiatrists don't prescribe it. We'll be talking about that. So that's a sampling of the topics, and there will be many others. And again, the podcast contents will meet the following criteria. It's observations that are not found in the medical journals. They're unknown to almost all doctors and patients, yet they make sense physiologically and pharmacologically. They are relevant to common medical conditions. And most important, I'll be presenting solutions that are simple, safe, inexpensive, and very quickly evident. So this has extreme practical importance. And of course, I encourage you to discuss the contents of these podcasts with your physician. In some of the podcasts, there will be time for Q&A, questions and answers. If you would like to submit a question following a podcast, you can do this by logging into my website, which is drsamuelmann.com. Click the icon for podcast, and then in the appropriate space, put in your question and information. I also will invite other physicians to be a guest, do a guest podcast, because other physicians will likewise have observations that are relevant and helpful that are not in the books. And if you are a physician or if you know a physician with relevant observations, also please contact me through the website, drsamuelmann.com. I urge you to subscribe to this podcast series. Subscription is free. I urge you to invite your family and friends to also subscribe. I think you will find it fascinating, clinically relevant. And again, subscription is free. And that's basically it. The first 2 podcasts coming up, one will be about that drug that causes mental dullness. That's widely prescribed. It's a bestseller. And another upcoming podcast is the one on ADHD. And again, I think some of the findings, even without formal studies, they are valuable and they are safe. And I look forward to presenting them to you. Thank you.